meeting. So thank you all for coming tonight. We have an exciting agenda this evening. It focuses on the latest from our VCSQI work groups, committees, and partners. So we're excited to show off the latest and greatest from all of our great VCSQI projects. We'll look at some data, and this, just as a reminder, is an open Zoom meeting. So we want you all to jump in, to chat, to unmute yourselves, to just communicate and interact and make this a collaborative meeting. So thanks in advance for not being shy and sharing your thoughts with us tonight. So our first segment this evening is a welcome and highlights from the board from our VCSQI chairman, Dr. Cotter. So Dr. Cotter, I will turn it over to you, sir.
Good afternoon, Eddie, for those remarks. Good afternoon, everybody. We're so excited to join here for this quarterly meeting. And as Eddie has pointed out, one of the key areas that I like to instill in our member group here is active participation. Active means just being able to express your point of view. As a matter of fact, one of the highlights of the board meeting today was able to hear, what everybody else has to say about certain things. And it was a very exciting meeting. And that's what I like the most about being part of a group, is to discuss, listen, and learn from the different point of views. And I will say that I wholeheartedly welcome every member who is participating here to either through the raising a hand or through a chat box or something like that. If you have a point to make, if you have something to say, please come forward, because that's what makes these meetings more exciting and interactive. The couple of announcements from the main board is to go over our strategic plan again, to reinforce that our mission of this organization is to transform the cardiovascular care with a particular focus on improving the patient experience and the value. And our vision is optimizing the heart care outcomes through collaboration, both within the state and across the nation, through innovation and research with the core values of value-based best practices. And as I alluded in the introductory remarks, collaboration and transparency, being able to hear everybody's point of view on what we are doing and how can we do better. The stewardship of healthcare and costs, and also to uphold the quality and patient-centered focus, and try to think outside of the box, be innovative, and use the new analytic methods out there to use your data to come up with some answers to the questions that we haven't even thought of before. So that's where we stand. What's the next slide there, Eddie? So a couple of things. I just want to, again, thank Eileen Doman from Mary Washington and Chris Sima of Winchester for their great services to this organization. And they have retired from the services, and they have left behind a big legacy, and I just want to thank them for that. The other announcement is that we have 3 new board members with a lot of energy, enthusiasm, and great ideas. Cindy Cole from Centera Lynchburg, Eva Dallas of UVA. Again, Eva brings a very different perspective that we haven't had on the board before, which is how they see things from the perfusion team standpoint of view for this whole. So I really welcome Eva and her input. And then we have Jeff Benke of Winchester. So I welcome all of them to this board. And then the treasury role was held for a very long time by Eileen. And we thank Dr. Robert Lancy for stepping up and taking that responsibility. And I'm very sure that he has had great experience doing this in the past at a different organization, and he will certainly contribute that valuable service to our organization also. Thank you, Dr. Lancy. The other big announcement is the efforts of Eddie and Sherri are bearing fruit again. As you could see that we have 4 more cardiology programs that have signed up since the last meeting, and to the total of 26 out of 43. So I really thank the efforts that you have put it in to make this happen, Eddie and Sherri. This is also to just take a moment to think about our next future quarterly meeting, which is going to be a hybrid meeting between in-person and Zoom. As we talked to the board, it's going to be a very exciting meeting because we have a full agenda as a part of Virginia heart, like, you know, the what do you call cardiac center, and they also have a very good speakers and everybody else involved and lined up for that one. So that will be a great meeting to look forward to it. And without taking more of anybody's time, I would just say that let's go forward to the agenda items of the meeting today, and then welcome the first speaker of the meeting.
Thank you, Dr. Cotter. So we will move into the portion of work group, committee, and collaborative updates from VCSQI. And our first update comes from Dr. Pete O'Brien from Central Lynchburg. Dr. O'Brien is the medical director at Centra's Cath Lab, the chief quality officer at Centra Heart and Vascular Institute, and also the co-founder of the Virginia Heart Attack Coalition, VHAC. Dr. O'Brien, thanks so much for being here with us this evening.
Great, thank you. Thank you to all our participants as well. Very exciting and always glad to come and speak to the whole organization about the Virginia Heart Attack Coalition and to give you some of our updates. Next slide. So I think you know who we are. We are a statewide STEMI system of care. This is our kind of our battle map here, showing the 6 different regions in the PCI centers, and we've been hard at work all year. We joined VCSQI, Eddie, I guess about 2 years ago, maybe about 1.5 years, but either way, time has gone by quickly and we're making a lot of progress. And again, very, very grateful to Eddie and Sherri and to all of you for supporting us. And this has been a very fruitful partnership. Next slide.
What are those red dots and the green dots? I mean, green,
yes.
What is the difference between them?
Great question. So I won't claim that these are up to the minute, up to date, but these are centers that were participating in a STEMI registry. They have not been updated for the VCSQI registry. So some of this honestly is left over from our days of action when that was our backbone, that was our STEMI registry. But those are all the PCI centers, and we hope to turn everybody green. I heard tonight we have 4 more centers, so that's exciting. Next slide, please. So I don't want to steal Eddie's thunder, but I just want to kind of give you a little taste of what we do and where we are right now data-wise. These are STEMI measures reported out by regions. Now, the slide I just showed you with that map showed 6 regions. We have one region, the central region, that's does not have enough participants just yet, but that's the area around Richmond and just to the south of that. But we're getting very close. We're recruiting more centers there. We have to have a certain number in order to display the data, because if you just have a couple of centers, it's not really region-wide data, and plus then it's easy to figure out who's who. And right now this is still blinded. But I think this slide is important. Again, Eddie's going to dive into all of this stuff here in a bit, but I think this is important to look at the metrics that we are continuing to follow. Door in, door out, I think people are familiar with the concept of DIDO. That is when a STEMI patient presents at a non-PCI hospital, how quickly they get seen, diagnosed, and out the door to the PCI center. And the goal there is ideally less than 45 minutes. That can be challenging for some centers that have to wait on long distance transport, but at least it gives us a goal to shoot for. Then there's the time in between hospitals that really reflects some of the geographic challenges in different regions. All of the regions, we all have challenges and barriers, but they're not exactly the same, say in an urban area versus a large rural catchment area in Virginia. And that just reflects that. Of course, first medical contact to primary PCI, this is really the key metric. This is really where this and the median time is really, I think, the best test of how we're doing. As you probably noticed, I don't say door to balloon. Door to balloon is important, but we've moved well beyond that. Door to balloon is really just one segment of the whole continuum of reperfusion time. And we're really looking at the moment that EMS lays hands on the patient to the point at which they have TIMI-3 flow in the cardiac cath lab. So, or at least device activation. And you can see we're doing pretty well there. The goal is greater than 90% of the time that this is done in less than 90 minutes per the guidelines. We're doing pretty well. But we also want to get faster and faster. And the final metric there shows median first medical contact to primary PCI for, these are for non-transfer patients, by the way. These are the patients that show up at a PCI center. And once upon a time, when VHAC really was starting to hit its stride, we set a statewide goal captured by the slogan, the drive to 75. And that was less than 75 minutes. And you can see that most regions are hitting that or very close to it. And our median statewide FMC to device time is 72.5, which is just kudos to all of our providers and the teams that are making this, making all of this possible. And again, Eddie's going to give you some more information on this in a little bit. Next slide, please. So where are we now? What's going to occupy our time, attention, and interest over the next several months? Well, that is strategic planning. I think that VHAC, which was founded in 2008, 2009, at a time in the state when the median FMC to balloon time was 95 minutes, you can see that we've made tremendous progress, but we still have persistent gaps, barriers, and opportunities. And you know, we're proud of what we have done. I'm very proud of the stakeholders, the STEMI leaders and team members that have helped us accomplish this. But I think it's time for us to really take a hard look at ourselves and say, how do we evolve? How do we get better? So we are initiating a comprehensive assessment, starting first with our core leadership. Sherri has really devised an excellent and systematic way to look at this. This is the SWOT analysis, which is, I think, a well-known tool, but I think this is going to be aptly applied to VHAC. So myself and some of the other leaders have our homework. We're looking at our successes, what are our weaknesses, where do our opportunities lie, and what are the threats? You know, what could derail VHAC? What could make VHAC less effective in the future? You know, one of the things that we said at the outset is all of us, to some degree, for much of our careers have been involved in clinical process improvement and quality improvement. And not to sound like a cynic, but we can all remember some flavors of the month that have long since withered, or mixing metaphors here, have long since gone away. We did not want to be one of those great ideas that ended up fading away. We want to be sustainable. We want to have a lasting impact on the care of STEMI patients in Virginia. So these are all the difficult issues that we need to look at. We're in the process of revising our mission and vision statements to really encapsulate what we're all about and what we are trying to achieve. Fortunately, we have the example set by VCSQI. We all went through this a couple of years ago, and I think came out a better organization. So we're not alone in this, and we've got some great institutional memory to help us in this process. Once we come away with the SWOT analysis, with a revamped mission and vision statement, we're going to go back to our members, and that the members being all of you, and even the larger family of VHAC, and say, okay, this is what we have. What do you think? What would you add to this? How can we better serve you so that you can serve the patients of Virginia? So that next phase will be the survey of the members. And then once that's done, we will bring everybody back together for a strategic planning workshop. We'll give you more information on that when that's ready. Absolutely encourage everybody who's interested to turn out for that. I think we are going to learn not only about VHAC, but also about VCSQI along the way. So I think this is going to be a very helpful exercise. Next slide, please. So the other thing that I'm very excited to tell you about is the September 14th meeting that is going to be roughly from about noon to 5, which will precede our usual VCSQI quarterly meeting. And this is very exciting for us for a couple of reasons. Number one, it's going to be in person. There will be a hybrid option, and we haven't had an in-person meeting since 2019. So we are really excited about seeing everybody again, about gathering together, hearing from these great speakers, and just bringing people back together again. So this is the tentative agenda. You can see we've got a great slate of experts and topics. Eddie's going to give us a data overview. Bob Page with the Office of EMS is a nationally renowned EMS speaker. He does a lot of pre-hospital EKG education. He was also part of the RACE project in North Carolina, really the kind of granddaddy of all STEMI systems. Ray Watley from Northern Virginia is going to talk about EMS engagement. We're going to really address, EMS, like the rest of us, have gone through some difficult times in terms of retention, hiring, burnout, things like that. And, I may be a cardiologist, but I'm completely dependent on my EMS colleagues to deliver good STEMI care. So it's going to be important for us to hear what they have to say. John Patterson, an interventional cardiologist from Southwest Virginia, is going to review 2 cases. Dr. Tarani is going to give us an update on SHOC and really talk about how they assembled SHOC teams and their hub and spoke model up there that was published and I think has really set the standard for SHOC systems of care. So we're excited about that. And then last but not least, we'll have kind of a rapid fire roundtable of the latest cardiology data from Dr. Kontos, Dr. Kaushik, and some others. So that's going to be exciting. And we'll wrap up in time to segue into the VCSQI meeting that evening. Next slide, please. So the work continues. I'm always recruiting. We need all of you. We need regional leaders. We need stakeholders. There's still a lot of work to be done in Virginia. So I would implore you to get involved with your own STEMI and SHOC committees. You all tonight are by definition the people that people look to in regions in terms of quality and clinical process improvements. So please stay engaged. Please help us out. Third Thursday every month, we have a call. It's just an hour. All are welcome. Honestly, I find that these calls and this involvement with the rest of the state, I think people have helped me more than I've been helped. Did I say? I didn't even say that right. I feel like, let me put it this way. I feel like even though I'm one of the VHAC co-founders and one of the leaders of VHAC, I have learned more than I think I have taught other stakeholders. So these are great opportunities to hear from other STEMI leaders, SHOC leaders, and to help them, but to take some of the best practices back to your own hospitals. We present data, we answer questions, we kind of plan the work of VHAC and VCSQI. So hope that made sense. But what I'm trying to say is these are great calls and they're open to everybody. So please, if you want to be part of these, just let Sherri know and she'll send you a link. There's a lot of other stuff we're doing that I won't get into. I'll wrap it up here. But one of the other things that I'm excited about are data manager workgroup calls. Again, these are also open to everybody. And what this does is this allows Eddie and Sherri and myself to gather together the abstractors, the outcome specialists from across the state for questions and answers, for advice, for moral support. One final thought, this came up, and I don't know what things are like at your hospital, but this was pretty eye-opening to me. We heard from a few data abstractors, outcome specialists, if you will, that their hospital systems have let more people go. And now you might have 2 data abstractors trying to abstract for 7 or 9 registries, which to me sounds a little crazy. So Sherri has put together a survey and has sent this out. How many data abstractors does your hospital employ? How many FTEs? They're into quality. Of course, they want to get this stuff done right, but do they put their money where their mouth is? How many FTEs are there to get this work done? And really, what is the right number? We hope to get a general sense of that, and really to inform us as to the state of quality abstraction of, I'll say, quality infrastructure in Virginia, but also potentially just to go back and say, hey, you know, the average number for this number of registries you're asking me to abstract for is 5. Why do we only have 1 or 2? And we hope that that will strengthen their position and give their leaders more insight. So anyway, that's a lot of work condensed into a few slides, but I will wrap it up there. And Sherri, I believe that's the last slide. It is. So thank you all very much.
Hey, Dr. O'Brien.
Yes, sir.
I have a question about this. I mean, I think this sounds like a pretty exciting and upcoming heart attack coalition group that you have. So from what you see, where do you think we have the biggest opportunities to improve in the area that you're working on? And how can VCSQI help in doing that?
That's a great question. And I would say absolutely engagement. I think that we have 6 regions, and I'll be honest, they vary quite a bit in terms of engagement. And what do I mean by that? First and foremost, physician engagement. Now, I don't say that because I think the cardiologist or whomever are more valuable members of the team than anybody else. I believe that VHAC, the foundation of VHAC, is on EMS, ED, nursing, and everybody else. But what I've found in areas that are struggling is you have some very passionate, eager nursing staff, EMS providers that don't feel like they have the physician support or a physician involvement. And we get that. Everybody's super busy, especially in this modern era after COVID. But I would say, short answer is engagement of our stakeholders.
Got it. Thank you.
Thank you.
Very good. Any other questions for Dr. O'Brien? Well, thank you very much, Dr. O'Brien, and we will look forward to the continued good work with VHAC. Next up, we have our Research and Writing Committee. Dr. Nick Teman is a cardiac surgeon at UVA. He directs the adult ECMO program, and he's also an intensivist for both their thoracic and cardiovascular ICU. Dr. Teman is the chair of our Research and Writing Committee, and he will share the latest and greatest from our researchers with the group tonight. So Dr. Teman, I will turn it over to you, sir.
Great. Thank you so much, Eddie. And I really want to thank everyone for the opportunity. I have the really good fortune of being the chair of the Research and Writing Committee as of this past year. And it's really some large shoes to fill. For those of us that are kind of in the VCSQI bubble, you may not realize how big of a deal the VCSQI is in the world of cardiac surgery. Every national meeting, people are talking about the VCSQI, talking about the work that we're doing. It's always, a call for other regions to develop similar collaboratives and truly highlight the work that we're doing. So, like I said, you may not fully realize how much your work is appreciated across the country, but we see it every time we go to a meeting. It's really fantastic. So I appreciate the opportunity. I want to talk to you a little bit about what we've done in the last year in terms of the Research and Writing Committee and kind of our productivity. So starting kind of chronologically in reverse order, just this past weekend, Dr. Young from UVA presented some work that we developed through the Research and Writing Committee, looking at the use of radial arteries in coronary bypass, and that was presented at the Society of Thoracic Surgeons Coronary Conference. The Mitral Conclave is a conference that is dedicated to mitral tricuspid valve disease and always takes place before the American Association for Thoracic Surgery national meeting. And we had 2 posters, both from Dr. Wisniewski at UVA, using data from the VCSQI and analyzing the repair techniques in mitral valve surgery, as well as the rate of tricuspid valve repair during mitral valve surgery. I think that nothing better highlights the impact that the VCSQI research arm has than some of our plenary talks that we've given within the last year. So, and kind of talks at national meetings. So at the AATS meeting this past year, Dr. Strobel presented a paper looking at the ELSO Center of Excellence and how that impacted outcomes after cardiac surgery and failure to rescue. And Dr. Wisniewski looked at our rates of venous thromboembolism after coronary bypass surgery and looked at predictors of that. And that actually utilized survey data that all of the centers at the VCSQI contributed to, and allowed us to look at our practice patterns and see if any certain practice patterns predicted certain outcomes. So I think a really great effort across the collaborative. At the STS meeting, the Society of Thoracic Surgeons meeting, this past January, you can see Dr. Strobel up on the big screen. He gave one of the plenary talks at the meeting and received the Chamberlain Award, which is one of the award given to one of the highest rated abstracts in the whole meeting, looking at outcomes in cardiac surgery patients across socioeconomic statuses during the COVID-19 pandemic. And then Dr. Strobel was quite busy at this meeting, also had 2 other oral presentations, all using VCSQI data. And then at last year's AATS meeting, Dr. Hawkins was also gave a plenary talk and received the Presidential Abstract Award for one of the highest rated abstracts, looking at the utilization of extubation in the operating room following cardiac surgery. And actually using that data, we have now applied and received a opportunity to use the national STS data to also answer this question. So a good example of using kind of our regional collaborative data to better pursue looking at the question on the national level. I believe this is accurate. I'm sure I probably missed some, but just a brief list of the 14 publications that came out of the VCSQI within the last year. So, I mean, this is just tremendously impressive for the whole group. And I can't take credit for any of this. This is Dr. Cotter and the predecessors before me that did all of this work. But I'm really happy to inherit the excellent productivity that this group has in terms of research, and looking forward to continuing this. But you can see, very productive both in terms of presentations and in terms of publications. I want to highlight another thing that we're very proud of is that we now have a statistician that's working with us in the VCSQI. Her name is Ting Wu, and she's basically kind of devoted and dedicated time for statistical support for projects that originate in our research and writing committee. So, not all of the centers in our collaborative have the availability of biostatisticians or research fellows within their institution. So I'm really hopeful that this leads to other centers being able to participate. It doesn't always have to be the UVAs and the VCUs. It can be other centers that have research ideas that we can now support with statistical support. So this is really exciting. We had a recent call for proposals that went out, and she's already started working with Dr. Burrell and Dr. Cotter from VCU on the first proposal. But we encourage you to reach out if you have any other suggestions, and there'll be another call for proposals in the future. So this is a very exciting initiative that we've brought to the VCSQI, and I want to thank the board for their support, the financial support for us to be able to do this. So in terms of our committee, it's open to everyone. We have cardiologists, cardiac surgeons, research fellows, statisticians, anyone who wants to participate is welcome. It's a virtual meeting the first Tuesday of every month at 5 p.m. Sherri and Eddie can share the link or reach out to us if you're interested. During these meetings, we discuss proposals that people have for kind of new research ideas. We review abstracts or manuscripts that people have put together for meetings or for publication in journals. And I think it's a great example of the collaboration that we have. And I think it's a very helpful and educational process. I learn something new every time from the other members of the committee. So like I said, everyone's welcome. We would love to have more support. And as I kind of embark on being in charge of this committee, I really welcome any feedback. If anyone has any additional suggestions about what we should be doing in the research arm, I know that VCSQI has a lot of different interests, and the quality improvement and other aspects are vitally important. But I do want to continue to see our research footprint continue to grow. And like I said, it's very well received across the country, and I only hope to see that continue. So thank you very much for allowing me the time to give you an update, and please feel free to reach out if you have any comments or questions or any feedback.
Thank you so much for that wonderful presentation there, Dr. Teman. Even though you have taken over the reins in the last few months, but you have always been my partner for the several years in the past. And I just want to let you know that you owe a lot of credit for having a lot of these things done, along with many of our members, especially our data managers and such. Without your help, we wouldn't be able to do what we're doing in here with this research writing committee. And I just want to thank you on behalf of all of us here.
Yeah, absolutely. Yeah, thank you very much to Eddie and Sherri for letting us do this, and like you said, all the data managers at all the sites that give us the data that allow us to produce this work.
Thank you so much, Dr. Teman. And again, everybody's data is included in our database. Everybody is welcome in this committee. So we encourage you all to join in, and we do have biostatistician support as well if you have ideas, but we need some help in terms of the statistics. We can figure that part out too. So hope you all can join us as part of the research committee. Up next, we will have highlights from our quality committee from the lovely Judy Smith, who is our quality committee chair. Judy is also the STS database manager at UVA, and she is also an ICU nurse who has been a regular contributor to VCSQI really since the group began, as far as I know. And she recently stepped into the chair position role for our quality committee, and we'll share the latest from that group tonight. So Judy, I will turn it over to you. Thanks for being here with us.
Thank you so much, Eddie. And I am super happy to be able to talk about the quality committee. You can go to the next slide. We've had a great year. We meet once a month on the second Tuesday of the month from noon to 1. And we usually review some outcomes and have great updates from Sherri for the work groups. This year, we've had some great topics, including some polling questions, heart failure, where Melinda Offer from the STS, who answers our FAQ, actually joined us. It was very helpful. In one of the regional meetings that I was able to find out that a center in Ohio had this great speaker on coding AFib ablation, and she spoke with us, and it was really great. If you were at that talk, we are still waiting for the answer to the question that is the atriotomy a cut and sew part of the ablation? I don't think it's going to be, but we are still waiting for that answer. We had VHAC present on readmission, and always interesting to hear from them. We reviewed hot topics, which was part of the AQO presentation, is how they handled the question and answers from our meeting, our STS meeting for the data extractors. So they actually kind of delved into the questions that people asked, and we were able to review some of that. And we recently did a talk on how to interpret your star rating report. Next slide. So coming up in 2024, we are looking to continue to review our outcomes and updates from our work groups, as well as focusing on coding and the minutia of getting this right, so that we're always going to compare apples to apples and doing the right thing and answering. So when you're writing those papers, we all know that this is, we're all using the same information, and it's just for the integrity of the database. It's so important that we all understand what the answers are and how we should be coding. We're super excited to be invited to the Maryland workshop on June 15th this year. We are canceling our call for next Tuesday, and we will have the opportunity to participate in this call. It is virtual. It's from 8 to 12. And there are going to be some speakers. Someone's presenting on coding the aortic section, and some FAQs and some other really good agenda items. I really encourage you. Not a lot of people from our group have RSVP'd to this, but I hope that if you're able to participate in that and you're a data abstractor or have an interest in this, I really encourage you to attend. One of the things I think, you know, when you get kind of down into the minutia of talking about yeses and nos and what the answers are, like everything we do is for the patients, that we abstract this data for the patients. You know, you can only improve that which you know that you're doing. And we are going to look toward having one of our quarterly quality meetings is actually a clinical meeting to really focus on questions that we have about how to read, because a lot of us have roles more than just doing the yeses and nos, but taking care of our patients and advocating for our patient care. I hope that if there's anyone on this call that might be interested in being on a panel or presenting or being part of just bringing your gigantic brain to our group and letting us ask questions, please let us know. Because I think it's so important that, you know, remember that everything we're doing is how we can improve care and help our patients. And I'm super excited that our Dr. Tribble will be speaking on retrograde cardioplegia and our call on August the 8th. That's our noon meeting on the second Tuesday of that month. Super excited about that. Next slide. And if you have any ideas for the quality committee, which would bring value, what would be helpful for you, please let us know. It doesn't have, you can, the great thing is Sherri made this link. It will go to all three of us. So please let us know if you have any ideas or things you would like to see in the future. And most importantly, next slide. Thank you for everything that you do, all of our physicians, all of our everybody, Sherri, Eddie, all of our abstractors, everyone. Thank you so much for everything that you do and participating in our quality committee and the support for coming to our meetings and for everything that you do to support their patients. We really appreciate you. Thanks so much.
Questions, comments for Judy and our quality committee?
So Judy, thank you so much for leading this quality committee. And you have always been a pillar of this VCSQI since I have joined this group 13 years ago now. Now,
Thank you
for the questions. Yeah, so you know, you do have from time to time a forum questions that you come up with, you know, how does other centers do, so on and so forth. What is the process of getting sort of, you know, answer from STS? I mean, do you have a point person that you folks have identified that you send the question to them to get the answer? Or do you just work among yourselves to find the answer?
No, that is a really great question. That's a great question. So in the on our STS site, there's an FAQ mailbox. So say we had a question about, does a mitral valve, if you have a transcatheter mitral valve, that counts as and you're going to go on to have mitral surgery, that makes your open mitral surgery a redo. But if you have a mitral valve clip, that does not count as mitral surgery, and that will be your first incidence of cardiac surgery. Now, that's an incredibly important thing to get right? It's in the risk model. It's going to increase your risk. So it's really important that you get it right. So I sent in the question just to clarify, because we have a training manual with all this written out with great examples. So we have more than just the data collection form. We have a kind of like a training manual where it's got like lots and lots and lots of things written out to it. But connected to that is a person that has a relationship with the STS surgeons. And so, for example, she's the one who has to take that question about the atriotomy counting as a cut and sew AFib ablation line, which I don't think it will be, but she's taking that to the surgeons to let them decide. So we do have an FAQ mailbox that we send our questions to. And then when we get those questions back, then we all share them together. That's part of what we do in our group. Like I ask this question. If it's, you know, sometimes it's something specific just to me, I might not share, but like we share the answer for all of us so that we all know what we all learned. But thank you for asking that. That's a great question. It's very objective and it's handled by one person. And if she doesn't know the answer, she takes it to the STS surgeons.
Very good. Well, thank you again, Judy, for everything you do to help us ensure that we capture high quality data and are able to improve patient outcomes based on such a solid database here. Our next segment is our AKI work group. So this is co-chaired by Mike Brown, who is the Director of Cardiac Surgery and Structural Heart at Mary Washington. He also serves as their lead perfusionist, and Mike is just a great guy. He's another VCSQI veteran who's been around for over a decade here with our group, and he'll provide updates tonight from our AKI work group, which is convened over the last couple of years here.
Thanks, Eddie. So my co-chair, she retired, and so she left me with this. So I just actually went back into my email just to see how long this committee has been active, and we've been active actually since 2020. So there was a lot of work done by so many different people from many of the members of VCSQI. We really have not met within the last probably 6 months, largely because there haven't been many major changes to the protocol. We did actually, I want to go back to, I believe it was January, we did have an ad hoc meeting, and we made some changes to the protocol, largely because of an article that was published by Dan Engelman, and it was the article was a turnkey order set for the prevention of cardiac surgery associated acute kidney injury, and that was in Annals of Thoracic Surgery. It was published, I want to say, in December or January of 22, 23, and it really kind of mirrored our recommendations, but it was much more streamlined and less busy. I think it had a much better flow to it and easier to follow. Wanted to create more of an appearance in our cardiac surgery component of the protocol and recommendations that it would be more useful to the clinicians, especially everybody that's involved, CVOR, surgeons, perfusionists, anesthesia. And so there were some things that we removed that were from the STS guidelines, which were, I think, largely not being deployed by many of the institutions, such as using dopamine, intra-aortic balloon pumping for AKI prevention in low EF patients. Use of ANP and phenoldiazepam was removed. Those were all class 2, 3 recommendations. We took those out. We did make some additions in the post-op section as well, which is a modification of hydration protocol. And then we added some of the aminoglycoside component and the glycemic control updates to that section, because that was emphasized as well in the Engelman article. In the intra-op section, we just removed classifications just so that it looked less busy. We added the glycemic optimization control or control optimization post-operatively, preoperatively. We made some changes, very simple stuff, just for pre-op and post-op BON creatinine testing, blood pressure management, fluid management, and then again, remove the classification just to make it less busy, timing for nephrology consult and obtaining GFR, and we changed some of the nomenclature, such as anuria to oliguria. I think Sherri's going to speak about some of the protocols that we've implemented over the last few years and adoption by the VCSQI members. One of those components will be the AKI protocol, and I'll be interested to see how much these protocols have been adopted, but specifically this protocol by the members. I know I spoke with a number of programs, and there has been at least adoption of some of the components. We have not, at our facility, have adopted in its entirety because it is pretty comprehensive, and it's hard to get everybody on board and all those components in such a short period of time. But we have adopted some of the major things like DO2I monitoring and perfusion, and we're seeing we're kind of moving the needle as far as AKI from an outcome standpoint at our institution. I'm hoping others that are implementing some of these recommendations and suggestions that they're seeing that as well. But that's all I have for this time. Thank you, Eddie, for the opportunity to speak. Any questions anybody has, I'm open to answer.
Hey, Mike, thank you so much for that
Sure.
wonderful synopsis of the years of hard work that you and your team has put together in coming up with this protocol. And I have to say that having worked with Mike for so many years, he's a voice of reason. He's a voice that who brings innovations and ways of thinking differently. And more importantly, trying to make things practical. That's something that I really enjoy working with Mike, is he not only comes up with things, but shows how they can be done. That's a critical thing. And one of the things that he's taking up right now that he briefly mentioned is the oxygen delivery while the person is on the heart-lung machine. Can you briefly talk about that one, Mike, and just say, how you monitor that and how, to implement that in other programs, and what could be the big barriers that you may foresee in implementing that?
Sure. I will say that I'm not sure why there's an echo there, but from my perspective, it was a huge challenge for us. I'll be as honest as I can. We had issues getting it implemented, largely because of our interface with Epic. It took us about a year to get DO2I, the integration of that calculation into our Epic, basically our Perfusion Epic flow sheet, which is our documentation and monitoring tool that we use. We were able to work closely with Rono Carillion and Tom Akers, one of the perfusionists, to get that implemented at our facility. Largely, you've got to get the parameters that come from DO2 integrated into your EMR so that it can calculate it. There are other ways you can do it. We use a CDI, continuous blood gas monitor, and that will also allow you to do DO2 monitoring. But we wanted it so that it was easy for us to get it into Epic. And I know that a lot of perfusionists are having challenges with their EMR and trying to integrate it. And it was the easiest way for us was to be able to get part of the results from our blood gas, part of the information that comes from the heart-lung machine, such as the blood flow, and the hemoglobin from the blood gas. And we were able to integrate that calculation, and it shows up minute by minute in our perfusion on our perfusion monitor during the intraoperative procedure. Operationalizing it, I think, is critical to get your team to buy in because it does require a change. We did notice that we were transfusing a little bit more, not a lot more, but a little bit more, but only in very select patients. So a patient who may have, despite maximizing blood flow, which is your first step in trying to improve DO2I, in those cases where we felt like perfusion was compromised, and despite maximizing blood flow, and we couldn't move the needle, we ended up transfusing, or we would use a hemoconcentrator to try to increase the hemoglobin. In those cases, and we had some case studies that we presented at our monthly quality meeting. Whereas in years past, we probably would have seen AKI afterwards. We actually saw patients' creatinine go down, which was a big surprise for us. And these were patients with baseline creatinine of like 2.5 to 2.7. Historically, after a pump run, even despite attempts to maintain, a mean greater than 65-70 and quote unquote optimizing our blood flow, DO2I, you find yourself flowing a lot higher than you normally would, even at a 2.4 index at 37 degrees. And so for us, that's how we operationalized it. I know that at our facility, we wanted to use one of the perfusion specific software monitoring softwares for when our hospital went to Epic EMR, and we were denied that opportunity. So I know there might be other programs, and I think maybe VCU is now using Epic. I've talked to Adam, and I've talked to Mike and Eve down at UVA. Everybody has had kind of their challenges with getting operationalized, but once you do, I think it's pretty simple. After you get it operationalized, it's the buy-in that where the challenge might be. Eve, if you're on here, can you talk about your experience at UVA?
Yeah, happy to, Mike. I'm here. Yeah, very similar. It's like a two-pronged approach to it that, overcoming the technical challenge, which at UVA, we do have that kind of ancillary EMR system that very nicely provides us with a DO2 number. And then, the team buy-in that goes across the board. So it's a different and kind of a new and different conversation amongst the team in the OR that takes a buy-in from everybody. But we're having that conversation at UVA. For instance, just the other day I was in, and my patient's hemoglobin came back low, and I had seen my DO2 trending downward below a threshold, and spoke to the surgeon, told him what the circumstances were, and the decision was to transfuse. And so that's what happened, and then the DO2s recovered. Of course, I don't have any outcomes because I just got out of the OR, I think, Tuesday, but agree totally, Mike. It's twofold, and but it's nice to see the folks across the board kind of embracing that new number, even though it's not new, but the use of it and using it as a new tool for our patient outcomes.
And just to get back to what Eve is saying, that number is really 270, and it's indexed, based on BSA. The one thing that I think I didn't mention is that we had to sit down with our surgeons, our perfusion group, and our surgeons met and said, look, this is what we're going to need to do to be able to implement this. So we're going to need to use a larger venous cannula, and one of our surgeons uses a smaller arterial cannula. It's a straight tip, and we told him, said, look, if we're going to create some serious hemolysis in some of these cases if we don't go to a larger cannula. So it gets back to the whole team approach. So our OR team will ask us before the case, if we haven't pulled the cannulas already, hey, what do we want to put on the table? So when you first start, there's those glitches that you run through, but I think once you operationalize it, it's pretty smooth. And I think with every good story you have a bunch of good stories. There are some stories where there's definitely opportunities, and I'll share one. I'm not afraid to share that story. One of the issues that we have with interfacing DO2 or getting it to come up on our EMR and Epic is getting the results to come from our blood gas machine into Epic. And there have been some cases where, for whatever reason, because the network uploading those results and them getting hold in a secondary software before it's released to the lab, we're not seeing the DO2 calculated. And so it's weird. At that point, I will say this, it's like flying. I don't have my pilot's license, but it's almost like flying without what they said, you're flying by visual and without instrumentation. Because we did have a case where one of my colleagues was pumping, and that patient had some preoperative AKI, and you make that assumption that you're at a reasonable blood flow, but there's a hand calculation you can do. She felt comfortable that she was flowing at a above reasonable flow rate, and we didn't have the, when we went back and I looked at it, we actually probably weren't a DO2 of 270. We were at a DO2 of like 210, 220. And so I think this has been eye-opening for us as a perfusion group. Those are very few and far between now, but when you do see it, it's eye-opening. And in that case, that patient did have, it didn't end up being an acute renal failure classification, but did have acute kidney injury post-operatively, which, hard to say if it was avoidable, but I think there was some drainage issues, there were some volume issues, and just made the assumption I'm flowing okay, but wasn't really. So I just thought I'd share that anecdotally.
Thank you, Mike and
Sure.
Emma, for those thoughts. And Eddie, I would let you drive next what you have on your agenda.
Absolutely. Before we move to the next segment, I also just wanted to point out this is our first work group that has really collaborated and created a set of recommendations for both cath and surgery, and it really works into an entire patient specific, all the way from pre-cath to post-operative if they go on that far, and looking at mitigating AKI all across the spectrum. So just wanted to point that out. And for any of our members who are more focused on the cardiology side, please let us know, and we're happy to share these recommendations with you all as well. Shelly from Centera, who's on the line, has been instrumental in helping to lead the charge from that side too. So thanks for that, Shelly. So next up, we're going to stick with Eve here actually, and I'll give you a formal introduction, Eve, just because this is your spotlight here. So Eve is a perfusionist at UVA, and she's also a recently elected VCSQI board member. And Eve serves as the champion of our VCSQI perfusion work group, and she's going to share the latest data and other projects that are developed by the group this evening. So thank you so much for being here with us, Eve.
Well, thank you so much. I'm just really pleased and proud to join Mike in representing the perfusion community, and I hope by this point, and maybe in the near future, that you all will become accustomed to and used to hearing the perfusion point of view. That's our goal and our desire, to have that be a more comfortable space for all of us. So thank you, Eddie and Sherri. I just don't know what I would do without Sherri White. I'm going to talk a little bit about the metrics. It's the main kind of thrust of what the perfusion group has been involved in. I must admit that Eddie and I have worked primarily on these. I have had some feedback, a little bit of feedback from the perfusionists. We are seeking more feedback. If you know that your perfusion group is not privy to these metrics, please point it out to them and make sure they know they're available. It is a work in progress, and anybody out there that has some information or data or tracking or assessment that they want, please let us know. Eddie is a magician, and we can probably make it happen as long as we can dig it out of the data. We currently have these metrics were born out of some conversations I had with the president or past president of the Michigan Perfusion Society. You may or may not know the involvement of the Michigan folks with the Perform perfusion database. It's large, and they have been running for decades up there and have produced some kind of massive data for those folks. And there are a few institutions here in Virginia that actually participate in the Perform group. I don't know who they are because they're blinded as membership, but I know they exist down here. So that was the beginning of this. He suggested that was a good starting point for this perfusion group, and so that's what we did. We currently have 15 running metrics. We're happy to develop more. Like I said, if you all on the call or your perfusion groups are interested. They're kind of designed to draw out the perfusion specific information out of STS. That is to assess and track some of the data that we feel is directly impacted by the perfusion practices. Eddie, do you want to, I'm going to just kind of whet your appetite today. We're not going to go through all of them. But again, if you're interested, at the end, we're going to show you where to go with your QR code. And Sherri set all that up for us. This is one of the slides. We looked at this at the meeting earlier tonight. I think this is a really interesting slide, and it's one that we can see a lot of information on. We're talking about pre and intra-op hematocrit versus intra-op transfusion rates. And so as you'll see, the normal grouping of institutions by low, medium, and high volume. We can see for each institution what their average preoperative hematocrit is. And so that's an interesting statistic for those people that may be working on some preoperative anemia clinics. With this slide, you can track what results you might be getting with your pre-op anemia clinics, as well as just what your patient looks like when they're getting ready to come into the OR. The blue bar, of course, is your intraoperative hematocrit. So we can see here the effects of any kind of interventions that your perfusion group and your surgical group and your anesthesia group together are performing for your patient. You can see how well you are performing those practices and optimizing your intraoperative hematocrit by that blue bar. And then we've lying over that is somebody can't hear me. Can anybody hear me?
Yes, we can hear you.
Okay, I'm sorry, Megan. I hope your sound comes back. And so you can see that we have over there the line graphs indicating any intraoperative blood transfusion and red blood cells. And so I find it I don't know if you can see trends. I don't know as the quarters go by and these metrics can build on themselves, what kind of trending we'll see, but I think it's useful for each individual institution to be able to look and see where they lie on that chart. I hope you'll find it useful as well. These are, by the way, all on-pump cases. It is not broken down between cabbage or valve. If we can, Eddie, skip over to maybe number 6 or so. That slide is entitled AKI versus pre-op anemia, cabbage only. Yeah, thank you. So you can see this again. I'm just whetting your appetite here. There's a lot more data. There's a lot more data to see. There's a lot of information to get out of some of these slides. But as always, AKI is important. It's what everybody's thinking about. You can see here the prevalence of AKI stages 1, 2, and 3. Again, this is cabbage only, N of 6,900. And you can see between pre-op anemic and not anemic patients, the significant p-values on each one of those stages of AKI. Again, note that percentage of prevalence of the stage 1 is scaled 0 to 35, and stage 2 and stage 3 are scaled 0 to 6. This slide, when I showed it to some people at UVA, sparked off quite a few conversations. Any comments, questions? I'm only going to show you one more slide. It's the next one, Eddie, please. So this is AKI versus intraoperative hemoglobin at less than 7. So that would be like a nadir hemoglobin of less than 7 on bypass, cabbages only. Again, note AKI stage 1, 2, and 3, and the scales for 1 are 0 to 35, 0 to 6, 0 to 6 on stage 2 and 3 as before. And the significant p-value between allowing your patient's hemoglobin to drift down less than 7 during your bypass run. Any comments? Anybody out there?
This is a pretty interesting data, I have to say that, Eva, and thank you so much. It must have taken a lot of effort and energy to put this information together. Are these numbers that you're seeing in, for example, like in the AKI, is it after the recovery from the operating room, or you guys are just like seeing some numbers in the operating room and you're using like the highest creatinine value during that hospital admission?
Yeah, I don't know, Eddie, if you can pull up the STS. We're using the STS standards or definition for each one of those stages.
And Judy
Dr.
can
Carter, this is
speak to the,
low.
yeah,
Yeah, this is the lowest.
Judy's got it. Go, Judy.
So this is the lowest hemoglobin. So one of our questions is, what was the lowest hemoglobin and hematocrit during the OR, your entire OR time? It's generally on pump. But that's what we record. We look at every single hemoglobin and hematocrit recorded and take the lowest one. Then we take the peak creatinine during the hospital stay, and that, so they could be there an entire, 2 months or 5 days, right? We're going to take the peak creatinine, and that is what Eddie uses. It gets a little bit, with the Aiken does have some time on it for like a stage 1 is within 48 hours. We're going to just use that once during their time stay, their entire stay. So with Aiken and the Kadigo, like there are some timestamps. But you need to know that the value we use is the creatinine, the peak creatinine during the stay.
Thank you for the
Stage 3 is
clarification.
yes, no to the question.
Yeah, absolutely. No, Judy, you always have answer for my questions. So you're taking the nadir hemoglobin in the operating room, and you're taking
bypass.
and you're taking the peak creatinine during the hospital admission.
Right.
That's a true reflection of obviously what's the lowest hemoglobin that they had and what is the worst kidney function that they had during the hospital admission. Yeah, this is a very compelling data. Thank you so much for sharing with us.
You're welcome. So like I said, that's just to whet your appetite a little bit. We can go to Eddie, if you don't mind, please, the last slide that Sherri prepared, and we can sit there. I just had a couple of other comments to make about the perfusion group. The perfusion group doesn't meet on a regular basis, but you can contact us. As with the quality at VCSQI, perfusion at VCSQI will get you myself and Sherri and Eddie, and so we can make some things happen. The metrics are available at the portal, and there's your QR code as well. We're happy to, again, any information you think might make the metrics better once you look at them in full, or provide your group with the information that they need, please just let us know. Eddie's the magician. Some of the other metrics that you didn't see tonight have to do with AKI versus time on bypass. Then we have, let's see, we do have metrics of AKI versus your intra-op hemoglobin less than 7, and then we add in transfused or not transfused. We also have AKI versus intra-op hemoglobin less than 7, and the number of units transfused, 1 through 4, I think is that number. So you can see that as well. We're tracking use of cerebral oximetry during bypass surgery versus intra-op transfusion. It's interesting to see if you use your cerebral oximetry more frequently, do you transfuse more frequently based on what the readings that you're getting on your brain transfusion, oxygenation. We have metrics that track our bypass cases that have had previous CV interventions, and we track cases that have had previous transcatheter interventions. And so all of that's available. Please go and hunt it down and then let us know what more you want or what do you want to see. For instance, I was thinking from our meeting earlier, Dr. Cutter was thinking maybe we need to risk adjust some of these statistics as well and make them more useful and to folks that want to use them. In addition to the metrics development, a couple of other things. We're currently asking Eddie to help us use the new TAVR data. I think, Eddie, correct me if I'm wrong, but I think we're still the only ones, or the first ones anyway, to delve into some of this data, the TAVR, the TVT data that's at the VCSQI now. And so we're happy to be doing that. Initially, our focus is to kind of define some populations and search out for some associations and outcomes. Mike Gelvin and I at UVA for several years now have been interested in trying to develop a kind of a risk model for bypass for our TAVR patients. Luckily, the N on patients that convert to bypass is so small that it becomes kind of problematic based on the database. But we are working with Eddie and we're developing some associations, some outcomes, and we'll be happy to let you know what we come up with in the future for that TAVR data. And welcome all of those institutions that are not currently contributing and not a part of that TAVR database with VCSQI to consider joining so we can increase the power of that research. And then I wanted to say that we are trying to develop a next survey for the perfusion group. We want to be able to collaborate between the Virginia group and the Maryland Perfusion Society, as we did with the RAP survey that we did a couple of years ago. And that survey is going to be focused on hotshots and cardioplegia. And so if you or your group have any issues or questions, want to know anything about what other groups are doing and how they're practicing and using hotshots and cardioplegia, let us know, and we'll do our best to build that into the survey so we can get those questions answered. And then we look forward to coming back and presenting those results to everybody as well. I also want to mention membership because it's important that we get as much contribution from your perfusion group as we can. And so again, hit this page, go back to your group, go back to your perfusionist and ask them if they're participating and if they think that these metrics would be important to them. We don't meet. We're not going to ask them to meet. We're not going to ask them to committee. We're not going to ask them to do anything, but just join the group, look at the metrics, receive the metrics, help us to make them the best that we can so that perfusion can continue to contribute our part to the whole of cardiac surgery. And so I think that's my abbreviated talk today. Does anybody have any other questions or issues?
I have one follow-up question. It's very good, what do you call a nice group, like support group that you have there for the perfusion group. And through that, a lot of data will be filtered and then will come to the VCSQI as at-large community. One of the metrics really I like to see, perhaps, maybe in the future presentations, along with that native hemoglobin and the AKI that we saw, if there could be a third bar that shows DO2I.
Mm-hmm.
What is the native DO2I on those patients? And then that would really bring up a lot of validity to what you and Mike are proposing to keep it moving forward. Yep. Wonderful work. Thank you so much. I'm going to let anybody else who have questions to ask Eva.
Well, thank you for that comment. And you're spot on with that. It does get, I think Mike will back me up on this. And I think the DO2, the studies have shown that considering just the nadir DO2 over the extended bypass run is less likely to be indicative of some kind of AKI or other kind of organ injury than area under the curve or time under the curve. And so while we can do that and we can present that number for those folks who are able to put their DO2I on their perfusion record, we may be able to produce that number. But, you know, again, as studies show that it's really area under the curve rather than nadir, we got a ways to go. But yes, thank you for that comment, and certainly something to think about. You know, maybe Eddie and I can put our heads together, or Mike and I can put our heads together and see what, if anything, we can come up with to begin, you know, as a starting point for DO2I tracking.
Yeah.
Thank you.
If you don't mind me jumping in there, as Eve was saying, the challenge is that it's just tracking it. I mean, I've kind of beat Eve up about it. She doesn't answer my email because I'm joking. I really would love to do a study on DO2I, but it is really a challenge on how, you know, our practice, not our practice of how we achieve a DO2I, but how we collect the data and how she would collect the data and how somebody else. That's the big challenge that we're up against. And then within Epic, for us, I've been able to create a DO2I report, but it's just the logistics, because when you tell us to turn the flow down, or when you're weaning off bypass and you're at half flow for a period of time, that DO2I goes into the dumps. And so even though you're adequately perfusing the patient, it's coming across as bad data. So it's how do you accurately calculate that area under the curve that's the challenge, because I would love to do this big study, not necessarily proving ourselves right, but just are we really doing the right thing? But that's the challenge. And being able to get my data with her data and with Adam's data at VCU and somebody else's. You know, there was a study done at Hopkins where they looked at blood pressure control and DO2I, and I want to say maybe ultrafiltration. And it was a nicely done article, but they were able to show a direct correlation between DO2I and blood pressure management and AKI. But doing a multi-center study, I don't think anybody's been able to do that yet.
Yeah, I just don't think we're there yet. I think that, you know, I think our practice has caught up to the concept, but the technical side of it and the record keeping side of it is just not there yet. But we will keep that on the radar for sure, and, you know, continue to kind of consider what maybe a piece of it or a part of the DO2I calculation that we can draw out. We'll see. Thank you so much.
Thank you, Eve, for leading this group and for creating a compelling set of metrics here that, again, I encourage everybody to check out at our members portal here. So next we have a few updates from Sherri, and Sherri, of course, is our VCSQI Quality Improvement Advisor. So without further ado, I will pass you the rock here, Sherri. The floor is yours for first up, cardiology database managers.
Why, thank you, my dear best partner, Executive Director of VCSQI, Eddie Fonner. I appreciate you. Thank you all for joining us this evening. I just have a couple of quick updates for you for some of our work groups. So first up, we have our cardiology data managers meeting. And here is just a snapshot of more information about this work group. So we meet on a monthly basis. It is the third Wednesday of every month. This meeting is attended heavily by Dr. O'Brien from VHAC and Centra. Thank you, Dr. O'Brien. I believe Dr. O'Brien, with his presence, it helps to bring more collaboration between cardiologists and data managers and help to understand both perspectives. So thank you for participating. One thing Dr. O'Brien does is take the information he garners from the data managers meeting and report it back to the VHAC meeting. And data managers are also participating in the VHAC meeting. So it's a great forum. We do not yet have a champion for that work group, but I have a few in mind that I'm going to reach out and invite. Currently, we are working on a data manager survey. This was an idea that was sparked at our last meeting, I believe. A few of our data managers were just talking about burnout and managing multiple databases. And what is a standard of FTEs that should manage a specific registry? So Dr. O'Brien had a wonderful idea. Let's create a survey and let's come up with a standard for VCSQI and VHAC and develop it and send it out to the group to be a standard of management or extracting data and what tasks to be associated with each registry, if you will. So this survey had already gone out to our PCI, Get With the Guidelines and Chest Pain MI data managers. A few of our STS data managers have completed this, but here's the QR code and a link below it is the link to the survey. I will send out an email to everyone to participate in the survey who has not yet submitted a response. The way we developed this survey is kind of tricky. I can't believe I pulled it off, but let's see if it is working. 22 responses so far. So if your organization does not participate in a specific registry, you have the option of skipping it. If your organization participates in the registry, but you don't know the information, so we're asking for how many FTEs, how many hours are put in, what are the associated tasks, things of that nature. So if you don't know that answer, you can skip it and send the link to someone else to complete it for you. But overall, we're going to create a snapshot for each program and come up with a consensus of what we feel the recommendation should be for managing these important databases. And I'll pause for any questions. Okay. Next up, we have our readmission work group. And on May 10th, we actually had a wonderful information session partnering with VHHA, Virginia Hospitals and Healthcare Association. We've been pulling off this work group or meeting with this work group for over a year, I believe. This is led by Dr. Robert Lancey from Centera. He has so much energy, so many ideas, and the participation of the members is just so exciting. So we're continuing to work through this work group. We do have a set of recommendations prepared. This work group was developed to enhance the VCSQI readmission protocol that was developed around 2016. At that time, it was focused more so on a patient navigator or nurse navigator, a discharge planner for patients. This set of protocols or this set of recommendations is intense. It's broken down by different areas, pre-op, post-op, intra-op. It also looks into the social determinants of health. And we're currently working to figure out if we can come up with a guideline or a tool and an assessment of what to do with those specific determinants. And also Dr. Lancey, the next step we're working on as well is creating a risk calculator. And we will reach out to our biostatistician to see if there's any help that can be offered in that regard. But it's a set of great recommendations, I must say. And it incorporates communication, it incorporates education, it incorporates listening, all aspects to reduce readmission. We also launched an initiative of sharing shared strategies. And we had our own Robin from UVA, who gave an overview of best practices that is done within their organization to mitigate readmission. So if you haven't seen that already, it's on our VCSQI website, check it out. And if you have any recommendations that you would like for us to record or capture and share with our members, please let me know. I really enjoy creating those videos and I would love to create one of you. Thank you. Any questions? I'll pause. Okay, up next, we have the Perfect Care Network. We've been partnering with Kevin Lobdell from Atrium Health in North Carolina for a few years now, maybe 3 or 4. So over the last year, maybe almost 2 years, we've been working and we've actually expanded the Perfect Care Network to include Maryland. So it's now inclusive of Perfect Care, which are some centers in North Carolina, VCSQI programs within Virginia, and MCSQI programs in Maryland. So it is a collaborative across state lines, and it is so amazing. Attended, you will be energized for the rest of the year. So we had a spring meeting just this last year. Again, we talked about some best practices, focusing around deep sternal wound prevention, AKI, and readmission. If I can. And Perfect Care, we just wanted to give you an overview of Perfect Care. They have over 13,000 patients enrolled in remote patient monitoring. EACTS, 30th annual meeting, they gave a presentation on remote monitoring. And if you can recall, Kevin Lobdell attended many of our meetings, and one of the things that they do very well is the remote patient monitoring. So we do have an opportunity to learn more. Recent publications, here's a link, and we will definitely share this presentation with you so you can take a closer look at the manuscript that was prepared in this regard. And also one of the things that we are working with in this work group, or this network, if I may say, is work groups. So within the Perfect Care Network, we will establish work groups that focus around technology, and that will be EMR integration. We're looking at readmission. How can we take this across state lines? We know Dr. Lancy and the readmission work group team is getting together a set of robust recommendations. How can we take this a little bit farther? And also we're looking at goal-directed transfusion or goal-directed perfusion and AKI. Looking to gather a work group to create some development of pathways that we can just share as well. So if you're interested in participating in this work group or any of these work groups, please let me know and I'll be happy to sign you up. And the frequency of these meetings for Perfect Care, they're twice a year. We just had one in May. We may have another one in fall. So when the meeting is scheduled, just check out our news blast that I'll send out or on our VCSQI website for more information. And I'll pause for more of any questions. Okay, so up next, and I know you're tired of me talking, but I'm almost done. A few initiatives. I'm going to actually skip to the second one. The protocol implementation survey. So VCSQI have developed about 6 protocols over its history. A piece of the information that we are missing as it relates to looking at our metrics is how many centers have actually adopted some part or all or even none of the protocols that were developed. Knowing this information will help us to garner if the protocol, what areas or elements of the protocol are actually working and consistently, and also serve as a evidence-based tool to help us to increase or improve metrics for other programs that are not performing as well as others. So this survey, it's very quick, I must say. It does have a lot of skip elements. It's going to take about 3 minutes. Tomorrow morning in your inbox, if you are listed as a core contact for your program, you will receive this email. The email will ask you to participate in the survey. We're only looking for one answer from each program, from each center actually. So if you wouldn't mind, take a moment and fill out the survey. We want to know if you implemented the survey, the protocol, some, part, or all. Did you have any barriers? If so, what were they? We're interested in knowing what those barriers are so we can help prepare tools to help overcome them. We feel that if you have some barriers, there may be some common themes in those barriers that we can help to resolve. And also, what is the impact? So from your own personal perspective, what was the impact of implementation of that protocol? We have visual of the data, so we know what the outcomes were, but what are the things that we can't see? So take a moment and fill out that survey. And again, here's a QR code if you want to start it now. The link to the survey is also here, but it will be in your inbox tomorrow. And I'll pause for questions before I move on to the members portal. Okay.
As you could see, Sherri is very busy. And these are just some of the few things that she does on a everyday basis for our organization. We cannot be more thankful than that for her. One question, Sherri, regarding this like surveys, just a simple thing is, see that there are not too many steps involved before you actually get to answer the survey questions. One of the things that turns off a lot of people who get this survey is if they're asked to register. That's like a very bad word on the internet. Like, you know, that means give up your personal information, and then in return, you'll get like a bunch of junk mail. So if we could find a process that is streamlined towards just taking you to the question, that will improve or at least increase the return rate on these surveys. That's just my 2 cents.
Very much appreciated. That's how we learn, you know, just getting feedback. But if any of you should receive any information or any requests to register before you get any of our surveys, please let us know. That feature is turned off because we know firsthand myself, it is a headache. And then you have to verify who you are before you can do the survey. So if we want you to complete a survey, we want to make it as simple as possible. And if you see any ways that we can make it easier, please let me know. And with any of these surveys that I'm sending to you tomorrow, the data manager survey, the protocol implementation survey, let me know what that experience is like for you. I've done something different with these surveys to try to make it very quick and painless. So please let me know if it helps, because that can be the format that we use going forward, just to try to make things happen as quickly as possible. So I appreciate the feedback. Okay, let me find my screen. Okay, so let's take a look at our website. So this may have been earlier. We have revised our website, enhanced it, so to speak. We wanted to create a website that was, I would say Eddie and I will probably cheer in the background to make it easy, you know, looking for a form that a website base that was easy for us to update. So here's one. It's very seamless, very easy for us to update, but it also has a lot of tools that would allow us to communicate as a collaborative. And there's also areas where we can just, you know, have a secure forum, if you will. So this site actually protects information a little bit more. And that way, your information, you know, the data, the metrics, even though they're de-identified, we can secure them. So that was one of the reasons why we wanted to update this website and just kind of enhance it. But our website is still vcsqi.org. On the main page, here's the strategies for change I spoke about earlier regarding the readmission work. So please check out that video. It's a lot of great tips in there. I started sending out news blasts. So if there's something really quick for everyone to know, I've been watching the trends of those who read the newsletters and versus reading news blasts. And it seems like more people may be reading news blasts because it's very quick. So I'm paying attention to that. But if these are helpful for you, please let me know. But any news blasts that are sent are typically here on the website as well. And just the basic information. What I really wanted to point out for you was the members portal. But before I go, well, I have to sign in first. One of the things to remember with the members portal is that you have to sign up. So on the bottom of this page, just a FYI, actually there's meetings, there's testimonies, we have a lot of stuff on here. So be the first to know. That is actually signing up for our distribution list. If you fill this out, you will be on our distribution list. And I've added the specialties and organizations and titles because I want to start developing when we have information that needs to go out to a specific group. I want to send it to that specific group versus the entire distribution list. Right now, most of our emails are going to everyone because we don't know. We don't have a complete profile for everyone. So we're looking to get that completed in order to send targeted emails. But if you fill this out, that does not mean you have access at the member portal. To get access to the members portal, just click on members portal. Here, first you will get this thing to log in because it assumes you already have an account. If you don't have an account, you have to sign up first. And so signing up is just filling out this information. And here is the, are you cardiac surgery, cardiology? That collects the information for me to see behind the scenes, or Eddie to see whenever we want to send targeted emails to cardiology groups or surgery groups. So that's the point of this. But you have to sign up first. What happens after you sign up? Eddie and I will get an email. We have to manually approve you to be a member of the members portal. It doesn't happen instantly. Sometimes there may be a delay if Eddie and I are in a meeting, so it won't happen right away until we can actually go into the site to give you approval to be a member. And we're checking to see who you are. I did get one request from someone who wasn't a VCSQI member. So we're carefully checking the data just to make sure that you are who you are in a sense, because your information is valuable and we protect that. But once you have gotten the approval, and typically I send you an email to say you now have access to the members portal. But once you do, just click the email, type in your email and your password and log in. What I have found so far, and this is another project that I'm working on, there's one facility in particular who is having issues with signing up to become a member. I know that many hospitals, well, at least here in Cleveland, and I'm sure it's happening in Virginia as well, they're increasing the security for websites. So I believe we have to do a step further just to make sure everyone can access our website so that everyone can receive our emails by listing us as on the white list of your organization. But I'm investigating that a little bit more, but there has been one reported issue. Well, one issue of a reported center who's having access issues to accessing the members portal. But there's other options. Just let me know and we'll work it out. But once you're logged into the members portal, there's a lot of information that we are going to start having here. You can always go to the metrics. So there's a button here. And within this page is our folders of all the different metrics. And what you may have started to notice recently, whenever we have a new set of metrics that are ready to be distributed, I will save them here first and then send out an email blast for you to go and access it. So if you're looking for the data right away, this is the quickest way to get it. It's de-identified. And then once I go through the list and re-identify everyone or identify everyone, then I will send them out to the core contacts for each program. So this is just a method of my madness, but they're here. And they're also available to download. If you want to know more about our data and what is available, here's a button. As it changes, we do update this. So this is a number of hospitals, and we do have to update this. Number of hospitals that's participating, number of records, the years available. So if there's any type of research studies that you're interested in participating in, or just curious about where the benchmark is between you and other centers, just let us know, because this is the data that we have available. I'm also starting to put files that you can access for each work group. So for a readmission, for example, if you're looking to find the minutes, the recordings, or anything of that nature from this work group, just click on the link and it will take you to a shared folder where you can access the resources. But this is where we're going. The newsletters I'll save here. And if there's anything that you think that would help us to collaborate better, make things easier for you, easier to access, please let me know. Your wish is my command. Any questions, concerns? Okay. Well, thank you so much for your time. And with that said, I'll turn it back over to the wizard. We call him Eddie Fonner, who's going to show some data for you.
Thanks. Thank you so much, Sherri, and thank you for everything you do to help our quality improvement mechanism and processes run smoothly here. And Again, we hope folks can get on the website and start using that. And if there are any other requests, we're always available as well. So just let us know. We want to make this as easy as possible for everybody to join in however they can. So here we're going to take a quick look at our VCSQI latest reports that we have available across our registries. Sherri actually just showed this on a quick slide here. This is the data we currently have available. I did mention we have 26 members who are signed up for cardiology. We have only integrated 21 of those into the databases at this point. So there are a few more that are just kind of signing up administratively. But regardless, you'll see across the 4 registries that we have right now with our data warehouse ARMAS, there's nearly 250,000 patient records that we have as part of, one of the 4 major registries. This is also in concert with the UBO4 charge data from VHHA that we use to estimate costs across the registries, and we will have updated information on that in the near future as well. So these are our 4 main registries we're working on. I'm going to start with cath-PCI. Here's just a quick high-level overview of the last 2 calendar years broken down by quarter in terms of procedure volume. In blue, we have the aggregate PCI volume across our 21 member sites, and in the orange line, the PCI for STEMI volume. So I see pretty steady here. There are a few bumps up and down here. We've definitely seen a little bit more volatility since the onset of COVID. Next, we'll jump into some of the specific metrics for cath-PCI. Feel free to stop me if you have any questions. This is kind of the standard template you'll see for our hospital-specific reports, where, like Eve showed, our hospitals are broken down into volume groupings. These are based on kind of natural breaks that we've seen in the distribution of data. So low, medium, and high volume. The results are sorted within each category. So you'll see the blue bars in this case represent the most recent calendar year's worth of data. Those are compared against the previous calendar year's worth of data in yellow. And then within each volume group, the blue bars kind of stair step down. So they're sorted by performance within each grouping. And for the latest 4 quarters of data, those are compared against the green and the red VCSQI, and in this case, ACC benchmarks. And the last layer here, I know there's a lot, is we rate the hospitals based on statistical significance. So deviation from the aggregate rest of the group. With a plus sign, it means you are on the high end here. So this center, for instance, does more of their cases radially than the rest of the VCSQI combined, or with an asterisk, it means your performance is lower than that of the rest of VCSQI. So those are just some little statistical tests we built in to test for significance based on sample size and performance rates. So this first metric, again, is radial access site for all PCI procedures. So we're looking at about 20,000 cases across the last 2 years. See our overall radial average is about 68%, which is about 12 to 13 percentage points higher than the ACC average that we have here. And again, a lot of variation among centers. You'll always see that in our charts where, the VCSQI average might be 1 bar, but there will be a lot of variation around that mean. This is red blood cell or whole blood transfusion for, again, our PCI population. I think this is an interesting one, and Eve, we might want to talk offline, but I'm just wondering why our VCSQI average here is 2.5 times that of the ACC. Yeah, it's still pretty low. It's only 2%. It's low compared to cardiac surgery, but is this an opportunity for a new VCSQI quality project? We also have a number of risk-adjusted metrics in the database. So when we have a observed to expected in the title like this, that's what that OE stands for. So it means we're dividing the observed incidence or the observed rate of an event by that which is predicted by the nationally accepted risk prediction algorithm. So in this case, our observed rate for VCSQI is 2.4%. The expected rate would be greater than that. So it would be maybe 2.6%. And therefore, our OE ratio is 0.92. How to interpret that? OE ratio of 1 means your observed rate is exactly equal to the expected rate. Your performance is as expected based on your patient acuity and risk. Anything higher than 1.0 means you're performing worse than expected, but based on that predicted risk formula. And if you're less than 1, like our VCSQI average here, you're performing better than the national risk prediction algorithm predicts you to do. So in this case, VCSQI is less than 1, and you can see the distribution of hospital rates around that group mean.
Eddie, is there a reason the ACC is not 1? There OE? Or maybe I'm
I think
misunderstanding.
it's
what that
because they
0.88
haven't
is.
provided us with the recalibration coefficients, Judy, but I think that's a really good question.
Do they recalibrate like STS?
They do as far as their national reports. However, I haven't seen a set of coefficients like that of STS.
Well, we
So
can
for the
figure it out,
STS
right?
side,
Whatever we
you'll
gotta-
see the STS side, we'll see the rates are always at 1.0 because we do a little bit of an adjustment to kind of re-normalize the national mean to that 1.0 rate. But in this case, I think this is kind of a pre-adjusted or an unadjusted OE ratio. It's still risk adjusted. It's just you have to take into account what your comparator here is. Another metric in the PCI database we've been tracking closely is same-day discharge. So this is just for elective PCI procedures. As of now, over half of the elective PCIs are being discharged the same day across our VCSQI sites, which is in line with the national average here. But again, a great amount of variation between programs. Some are above 80%, others are just around 20%. The corollary here is average length of stay. This is PCI excluding other interventions. So across VCSQI, all patients is about 2.5 days. And we heard from Mike and Eve earlier on AKI. Here is our AKI rate for the PCI population. This is stage 1 AKI as defined by the rifle criteria. For across all VCSQI centers, we're at about 8% incidence of stage 1 AKI.
Matt.
One unique thing about our database is we can drill down into any of the elements across the data set and look at correlations within the data. So here is access site tracked against AKI rate. And in this case, we see over twice the incidence of AKI in the femoral population. This is actually another study we recently published on from the Research and Writing Committee, where we saw even when you adjust for patient acuity and risk, the femoral population still has statistically higher incidence of AKI across our population. And last for CathPCI, this is our in-hospital mortality observed to expected. I found this was really interesting because the OE ratio is less than 0.6 or about 0.54, but the observed rate is comparable to ACCs. So does that mean VCSQI's patients are really that much higher risk than the national average? I'm working with ARMIS to distill this, but this is just a compelling slide that I wanted to show. I'll keep moving here because I know we are on a little bit of a time frame. One other example from CathPCI, and this transitions into our STEMI data set, shows median door to balloon time by operator. So this is for our immediate PCI for STEMI patients. We're looking at door to balloon time as opposed to first medical contact, like Dr. Ryan showed earlier. So it's a slightly different metric, but regardless, this is one where we, again, want to see the patients treated as quickly as possible. So our median across all VCSQI operators is 61 minutes, but we see, again, a wide range of performance, anywhere from 32 to 159 minutes, and that's across 2 years worth of data. So this tracks with the measures that Dr. O'Brien showed earlier. I won't go through them again, but we're looking at a number of STEMI reports for our VHAC regions and also by VCSQI center. This is an interesting data set because we're combining data from chest pain MI back with data from Get With The Guidelines CAD. So we've kind of reintegrated those two registries that split a few years back. And we are now kind of blending and have created the infrastructure for a statewide STEMI database that all centers across Virginia can participate in. So here we're tracking it by region, and we can kind of at a quick glance see which regions are performing better and which ones can maybe have a little bit of room for improvement. We have also tracked this over time. So at this point, we have about 3 years worth of data in the registry. This shows all the 5 regions against the VCSQI total here in green. So overall for the median FMC to primary PCI, we are trending down slightly as a group over time, but again, you'll see the little bit of variation between the different regions here.
Hey, Eddie.
Go ahead, Dr. Ryan.
Great summary, thank you. Do we know with the recruitment of a group of hospitals in the central region when you think we're going to have a critical mass to bring that region online?
Definitely by the next quarterly meeting, we will have at least, I would say, 3 or 4 of the central region hospitals in the database. Right now, they've signed the member agreements. It's just a matter of getting the data uploaded. So we should have them on in our 6th region and kind of last building block in place here should be set in the next few months.
Excellent, thank you.
One other example I wanted to show based on trending of the regional data, we've shown it for all regions on the full set of reports. This is just for one of the 6 regions, but shows how you can track based on quarter of data. So in this case, the South region is trending in a faster treatment direction, as well as the VCSQI in general is looking down around 70 minutes within the last quarter's worth of data. Our last set of data slides here shows quick snapshot of STS. Here is our total open heart volume by quarter. This is interesting here. We're looking at a higher incidence of CABG cases. I don't know if things have finally rebounded since the start of COVID, but that to me looks like the most CABG cases we've done in quite some time here. And this is updated through Q1 of 23, so we do have the latest data here from our STS participants. Format here is the same. We're just looking at our 17 STS centers. This shows intra-op blood use, kind of like Eve was showing earlier. In this case, it's just a slightly different format. So against STS and the VCSQI benchmark. See, our top performing centers are in that 10 to 15% transfusion range. And blood conservation was one of the VCSQI initiatives that Sherri will be sending the survey out on as well. Here's a new metric for us, multiple arterial grafts. So this is isolated CABG patients with at least 2 or more grafts performed. We're looking at either radial plus IMA or dual IMA usage. And I know it's been seen as a preliminary indicator for long-term graft patency. So this is, again, just a preliminary metric we're starting to track, but we want to see how centers are doing. And in this case, there are a couple sites that have taken the lead in this area. So more to come here, but be on the lookout for our MAG reports. New onset AFib, this is one of our old friends here. VCSQI as a whole is around 23%, which tracks pretty favorably with where we've been historically. Sometimes we're above 25, so we're a couple percentage points better than usual and a few below the STS benchmark as well. This is, again, another one of the protocols that Sherri will be asking the group about. Prolonged ventilation observed to expected. This, again, is another risk-adjusted metric. And another area that I think we have worked on in the past in terms of decreasing extubation times. Renal failure observed to expected, of course. This is AKI stage 3. So it's the most severe form of AKI. Our VCSQI overall rate has gone down. We were above 1, and we're now right around that 1.0 benchmark. So perhaps we'll keep trending in the right direction as the centers adopt the AKI guidelines. Let's skip ahead a little bit. One other area I wanted to highlight here is 30-day readmissions. This is, again, another area that Dr. Lancy and the readmission work group have worked on pretty extensively. Perhaps some of the fruit is already bearing results, as we're looking at about an 8% readmission rate across VCSQI centers, which is, again, compares favorably against STS of 9%. So where are we going in terms of future reports? We're definitely going to look at updated cost reports across all of our registries, STS and CAP PCIs we've seen in the past, and chest pain MI and STEMI will be the next wave going forward. We're also developing some new metrics for TBT. So right now we have 7 centers a part of that database, with more to come online soon. That will be made available and on the members portal, as well as sent out to our participating centers here. in the near future, hopefully over the summer. And again, Sherri and I are always available. So for custom reporting requests, if you have an idea, you just want to see, your hospital's performance against the rest of the group, we can always generate that sort of custom data analysis. We take pride in being able to turn those around pretty quickly and just making use of the power of the VCSQI repository. So please reach out and let us know how you'd like to utilize the data, because this, at the end, is your data and needs to be used to improve patient care. So that's our call for action. And I'll just pause here to see if there are any questions, comments from the group.
Thank you, Eddie. That's what I could say. Thank you so much for helping so much with our reports and things I could never do in Excel, and just whip them up. I really appreciate it.
No, you're very welcome, Judy.
Well, it has been a wonderful knowledge gaining experience for me today, just being with you all, listening to this wonderful initiatives, information and data, the gathering and sharing. We are at the bottom of the hour, and with respect to everybody's time, I just want to thank you again all for joining today to make this a gathering, a successful learning and exchanging the ideas. If anybody have any questions, I will open the floor for anybody to make a comments for the future meetings. Please let me know. All right, looks like everybody wants to go home and have dinner. I won't blame him for that. And have a wonderful evening, everybody. Thank you so much.
Most sincere thanks to all our presenters. Hope everybody has a wonderful and safe summer. And thanks to everyone for being such an integral part of VCSQI.
Bye-bye.
Thank you.
Thank you. Bye.